Guys, good evening and welcome to this session where we'll be discussing a particular case scenario under the heading called as Clinical Thursday. Myself, Dr Nileshraj, faculty for Pharmacology from DocTutorials. Let's move on to the case discussion right now. Let's start with the case. A 61-year-old man, a very old age, is noted to have increased intraocular pressure on routine eye examination. Very direct case, right? Why? Because the patient didn't present with any symptoms. Just for during his routine examination, we found that his intraocular pressure was raised. The visual acuity was normal. Dilated eye reveals optic nerve damage, a classical feature of a particular condition. I hope around 99% of you would have come up with the diagnosis in your mind. Visual field testing shows mild loss of peripheral vision. Here there is a loss of peripheral vision, which means the central vision is intact and the peripheral vision is being gone. So this is characteristic of what kind of a diagnosis, guys. Of course, this is a case-based learning for pharmacology. So we're not going to be concentrating more on the diagnosis. We're going to be moving upwards and onwards towards the treatment process. So the patient was diagnosed with primary open angle glaucoma and is started on pilocarpine ophthalmic drops. This is the case scenario right now. Let's look further. With this case scenario, the learning objective of this case-based learning is going to be what is the pathology behind glaucoma, what are the types of glaucoma, how did the doctor measure the intraocular pressure for the patient, drugs used for glaucoma, the pharmacological part in it, use for pilocarpine in this patient, whether we can use pilocarpine in this patient or what is the use of pilocarpine in a patient with glaucoma. Is pilocarpine the appropriate first line drug for treatment for primary open angle glaucoma? These are the different questions you are going to be fetching answer in this next half an hour of session, where we will be discussing in detail regarding the pharmacology of glaucoma. Not only that, the pathology and diagnosis parts of glaucoma. Let's start with pathology behind glaucoma. What exactly is happening over here? So guys, consider here is where your cornea is. We have the lens in the middle. This is we have the ciliary body which is situated there, and the lens is going to be attached with the ciliary body with the help of suspensory ligaments. Before that is where your iris is. We have the iris before that. But we all know that the blood supply is going to be stopping up in the ciliary body. The lens will not receive any blood supply. Then how do we provide the nutrients necessary for the lens's survival? How do we prevent the friction from happening between the lens and the iris? Because we all know that iris constantly constricts and dilates. So whenever it's going to be constricting and dilating, it is going to be producing a frictional mechanism over the lens. How do we prevent that from happening? We have, like how we have oils for engines, we have a fluid which is going to be flowing from inwards towards outwards in those areas between the lens and the cornea. And that fluid which is getting secreted from the ciliary body is what we call it as exactly aqueous humor. The aqueous humor is going to be secreted and it gets drained out into the iridocorneal angle. This is what we call it as, this angle is what we call it as the iridocorneal angle. Now, what exactly happens in terms of glaucoma? This is what about talking about is the physiology of how the lens is getting the nutrients which is enough for its survival. But what about the pathology behind? In case of glaucoma, the point is there is accumulation of abnormal amounts of aqueous humor in the anterior chamber. Because of this accumulation, it leads on to a pressure which is being developed on the anterior chamber, causing a peripheral loss of vision. Now comes the next query. How come there is going to be accumulation of aqueous humor inside the anterior chamber? How? Because two major possibilities would be there. Point number one, either there is going to be increased production of aqueous humor. Either there is going to be increased production of aqueous humor or there is going to be decreased synthesis or decreased secretion of aqueous humor. Decreased secretion or excretion of aqueous humor. Either the production from the ciliary body is going to be more, or the drainage or the secretion of aqueous humor out from the entry chamber is going to be blocked because of some issues. So for understanding these two major concepts, like how it is going to be how there is going to be increased production and how there is going to be decreased drainage, we need to have a knowledge on how ciliary body produces aqueous humor. Point number one. Only if you know that, we'll know the mechanisms behind what are the different ways of how it is going to be increased. Is that right? Point number two, decreased drainage of aqueous humor, which means we have to know what are the different mechanisms of how aqueous humor is getting drained out. By that only we can understand how can we counteract this particular process. First, let's talk regarding increased production of aqueous humor. Consider here is where the ciliary body is. I'll use a different color, guys. Consider here is where the ciliary body is. Inside the ciliary body is where the aqueous humor is going to be synthesized. Aqueous humor is getting synthesized from the ciliary body. Three major factors are involved in the synthesis of aqueous humor. Point number one is where your carbonic anhydrase comes into action. Point number one is carbonic anhydrase. Point number two is we have a G protein coupled receptor. We know what is a GP protein coupled receptor, right? The receptors which is coupled with intracellular G proteins. It passes through the membranes 7 times. Fantastic. It passes through the membranes 7 times, and we have one more G protein coupled receptor. This receptor is nothing but your beta 2 receptor, and the other one is your alpha 2 receptor. What is the function of these individual receptors in the synthesis of aqueous humor? Carbonic anhydrase tend to increase the secretion or increase the synthesis of aqueous humor. Beta 2 receptor, a GS coupled receptor, I hope you remember that this is a GS coupled receptor. It also tend to increase the synthesis of aqueous humor. And point number three, alpha 2 receptors, alpha 2, I hope you remember that it's a GI coupled receptor. It tend to be inhibiting the synthesis of aqueous humor. I don't know whether you can see this. I don't know whether you can see that image or not. I'll be writing it down here. I'll be writing it down separately. Carbonic anhydrase tend to increase the secretion of or synthesis of aqueous humor. Beta 2 receptors also tend to stimulate the synthesis of aqueous humor. Alpha 2 receptors tend to inhibit the synthesis of aqueous humor. If you want to give a drug which is going to be useful in treatment of glaucoma, I have to block carbonic anhydrase or inhibit carbonic anhydrase, block beta 2 receptors, stimulate alpha 2 receptors. Not only that, what about decreased drainage? So we have to know the basic physiology of how the drainage is going to be happening within our eyes, and here is where the drainage concept is. In this drainage, we have two major mechanisms. The first one is trabecular meshwork. The second one is uveoscleral outflow. Trabecular meshwork and uveoscleral outflow, which is going to be the major mechanism of how the aqueous humor is getting drained out. The trabecular meshwork is going to be the major mechanism. Trabecular meshwork is the major mechanism. Uveoscleral outflow is a minor mechanism. Trabecular meshwork drainage is going to be intraocular pressure dependent. On the other hand, uveoscleral outflow is going to be intraocular pressure independent. So simply, this is the physiology of how the aqueous humor is getting synthesized, how it is going to get drained out. Now, what are the drugs which we have? Drugs which is increasing the drainage of aqueous humor is going to be targeting which area, buddy? Exactly, is going to be targeting either the trabecular meshwork or the uveoscleral outflow. Drugs which is going to be decreasing synthesis of aqueous humor is going to be targeting either carbonic anhydrase or beta 2 receptors or alpha 2 receptors. Is that clear? Now let's move further. This is the pathology behind glaucoma, guys. Let's look at the next topic. What are the types of glaucoma? Universally known types of glaucoma are there. Two major types are there. The first one is angle closure or acute congestive glaucoma, and open angle or chronic simple glaucoma. Apart from that we also have a glaucoma which is going to be on the developmental stage itself, developmental or congenital glaucoma. We have primary and secondary glaucoma. These are many major subtypes are going to be there, but pharmacologically we are going to be having a treatment process for based on two major classifications: angle closure or open angle. What exactly is that angle? That's what we're going to be talking about in the next session. How do we diagnose glaucoma? Three major points are there, guys. Point number one, intraocular pressure. Point number two, the angle which is there, whether it is blocked or whether it is open. Point number three, direct ophthalmoscopy. We'll look into that. Intraocular pressure, it is widely it is being used as a screening method of finding whether the patient is going to be suffering from glaucoma or not. Intraocular pressure has been calculated with tonometry. Normal it will be around 10 to 21 millimeter of mercury. There is usually a diurnal variation of 8 millimeter of mercury, but it's going to be diagnostic of glaucoma. But again, it is not the basics or absolute diagnosis of glaucoma. We have many different concepts to be explained, especially for direct ophthalmoscopy. What are the types of tonometry which we have? We have indentation and applanation tonometry. Indentation tonometry, the classical one which you have seen in your clinics, guys, we'll be having that indentation tonometry. We'll be keeping it over the cornea to look at the pressure which has been developed in the eyes, and that's what indentation tonometry is. That's how we are going to be calculating the intraocular pressure. Moving on to the next one. What is the use of this? Yeah, this is a gonioscope. Gonioscope with which we are going to be calculating or study the angle, because that's how we are going to be classifying a case into an open angle or a closed angle glaucoma. Of course, symptomatically we can easily classify them, because closed angle is going to be an emergency. We have to treat the patient within a period of 24 hours to prevent an irreversible vision loss. But anyhow, this gonioscope is going to be useful in calculating the angle. It needed to obliterate the total internal reflection. We know that this is the apparatus, guys. This is the gonioscope. We just put a fluid over there. We put it up over the cornea. Before that, it's always advisable to put a local anesthetic agent. Just put it up the gonioscope and use a slit lamp to look at the angle. What are the regions or what are the organs which is going to be visible in that angle, guys? This is the image of a gonioscope, and with this we have 6 major values to be remembered from inside towards outside. This is purely of ophthalmology, guys, but anyhow, as this is a case based learning, I don't want to leave any stones which is unturned. We have 6 major points. Point number 1, iris from below upwards, iris. Then we have ciliary body, then scleral spur, trabecular meshwork which includes non-pigmented and pigmented, and the last one is going to be Schwalbe's line. We used to call it as ICS and NPS. ICS and NPS from inside towards outside, iris, ciliary body, scleral spur, non-pigmented, pigmented and Schwalbe's line. This is the angle which we are going to be targeting on, and in case of obliteration of this angle, we used to diagnose them as closed angle glaucoma. If the angle is open, we call it as open angle glaucoma, simply. Now what about the ophthalmoscopy? As I've told, the direct ophthalmoscopy, when we look at it, we can have the cupping which is exactly visible over there, and this is what the cupping is, Cupping can be scanned with direct ophthalmoscopy. Nowadays, it is being looked as a screening mechanism of the diagnosis or preliminary diagnosis of glaucoma. Let's move on to the pharmacological parts, drugs for glaucoma. So till now, just as a small catch-up, what all we have seen, guys, we have seen a case scenario. We have seen about what exactly is the pathology behind glaucoma. Before that, we explained the basis regarding physiology of glaucoma. Then we explained regarding how to diagnose glaucoma. What are the types of glaucoma? Now moving on to the pharmacological part, drugs used for glaucoma. We have many important set of drugs. The first and the foremost important drug is going to be As I've told, we have the trabecular meshwork outflow and we have uveoscleral outflow. This is how the aqueous is going to get drained out, and we have carbonic anhydrase, we have beta 2 receptors, alpha 2 receptors. Trabecular meshwork and uveoscleral outflow both is going to be increased with prostaglandin F2 alpha analogues. PGF2 alpha analogues is going to be involved in increasing the trabecular meshwork outflow and uveoscleral outflow. Please note that uveoscleral outflow is the major mechanism of PGF2 alpha analogues, not the trabecular meshwork. Yes, trabecular meshwork is the major mechanism of aqueous is getting drained out. But PGF2 alpha analogues or prostaglandin F2 alpha analogues mechanism is not primarily based on trabecular meshwork. The mechanism is primarily based on uveoscleral outflow. What about the next one? Carbonic anhydrase. We have carbonic anhydrase inhibitors, beta 2 receptor blockers. Simply put, we have non-selective beta blockers. We don't have a selective beta 2 receptor blocker, is that right? Alpha 2 receptor, we are going to be using, yeah, exactly, agonistic agents, alpha 2 agonistic agents. This is the basis with which we are going to be explaining the concepts. Now let's move on further and look at the first important drug, that is prostaglandin analogues, which is given as OD because it's a very long acting agent. What's the mechanism of action? It tends to increase the release of MMP, matrix metalloproteinase. Exactly, I hope if they have not known, fluoroquinolones. What are fluoroquinolones? Floxacin agents, ciprofloxacin, ofloxacin, etc. This set of drugs also has an important activity on matrix metalloproteinase, which also is one of the causative agent of why ciprofloxacin or ofloxacin might land up in Achilles tendon rupture. I hope you remember that. This is the mechanism behind. Increased release of matrix metalloproteinase leading on to digestion of ECM, thereby it tends to produce, as I've told, increases uveoscleral outflow. Point number 1, this is the major mechanism, mild increase in the trabecular outflow. What are the drugs which we have? We have latanoprost and we have bimatoprost. Apart from that, we have tafluprost, uniprostone, many different drugs are there, but mostly used is latanoprost and bimatoprost. Latanoprost is given as 0.05% solution. It's a PGF2 alpha analog. Please note that it must be refrigerated before opening, because when exposed to normal temperature, the drug's efficacy might be lost. We have bimatoprost. It is given as 0.03 to 0.01% of solution. It has got dual actions. Dual actions means it tends to have both increased excretion and decreased production. Bimatoprost, it has got two mechanisms of action. Bimatoprost has got bi action or two actions. It tends to be decreasing the synthesis. Also, it increases the excretion of aqueous humor. The next one, beta blockers. Name some non-selective beta blockers. Yeah, the drug name will start with T, right? Yeah, timolol. Fantastic. Timolol is a non-selective beta blocker. What's the mechanism behind it? Tend to decrease the aqueous formation. Aqueous formation is going to be blocked because of beta 2 blockade. Remember that. Here, if you use a cardio-selective beta blocker, it has got very minimal usages in this area, because beta 2 receptor is what is involved in the synthesis of aqueous humor. Beta 1 receptor blockade, of course, is going to be useful, but not as much as beta 2 receptor blockade, because it is going to be decreasing due to decrease in ocular blood flow, because there is going to be decreased cyclic AMP. Why there is decreased cyclic AMP, my dears? It's because beta 2 receptor is a G, yeah, it's a GS coupled receptor. GS receptors tend to stimulate what effector organ? Fantabulous, adenylyl cyclase. If adenylyl cyclase is getting stimulated, there is going to be increased cyclic AMP. Here we are going to be blocking the beta receptors. So what is going to happen? Decreased cyclic AMP. Apart from that, please note that it has got no effect on aqueous outflow. It's a previously asked question, buddies. Which of the following drugs has got no role in increased aqueous excretion or increased aqueous outflow or increased aqueous drainage, any different nomenclatures which you have. Beta blockers doesn't have any of the responses in those areas. Famous drug we have timolol. It's a non-selective blocker. It has got high clinical safety, but unfortunately it might also precipitate bronchial asthma. Why? Because see, we have a book called as Bennett Brown's, guys, right? In that it will be given clearly that whenever you use double the doses of timolol eye drops, timolol usually is administered as eye drops to the eye where the patient is having glaucoma symptoms. When it is given as double the dose, like if you want to put 2 drops, instead you have put 4 drops for that, there is more chances of the drug to be absorbed into the central circulation, causing cardiovascular abnormalities. Because of course it's a beta blocker, it tend to be producing bradycardia, it might be producing bronchospasm because beta 2 receptors are getting blocked in the bronchus. What are the other safer drug alternatives which we have among the beta blockers? We have betaxolol, levobunolol, cartiolol, metipranolol. Betaxolol, it's little bit more cardio selective in nature, but we have levobunolol, cartiolol and metipranolol, which is of more ocular use. Moving on to the next one, alpha 2 agonistic agents. Alpha 2 agonistic agents, and why are we doing that? Because alpha 2 is it's a GI coupled receptor. If I inhibit alpha 2 receptors, what is going to be happening? Atyl cyclase is going to be blocked, thereby the cyclic AMP is going to be inhibited directly. Alpha 2 agonistic agents, and what's the mechanism? Please remember, decreases aqueous secretion and increases ovoscleral outflow. 2 mechanisms are there for alpha 2 agonistic agents. Remember this with this mnemonic, alpha 2 always 2. Remember this, alpha 2 always 2, which means alpha 2 agonistic agents will be having 2 mechanisms of action. Number 1, it tend to be decrease in the synthesis of aqueous humor, and number 2, it increases the aqueous drainage. Both the mechanisms will be there for alpha 2. What was the mnemonic once again? Alpha 2 always 2. What are the drugs? A famous drug which we know, and that is I hope you remember that, clonidine. Yeah, clonidine is an alpha 2 agonistic agent. We have some drugs which is derived from the structure of clonidine. We have 2 major drugs, apraclonidine and brimonidine. Apraclonidine and brimonidine, all these drugs are clonidine congener forms. Out of these 2, lipophilicity or the ability to cross the barriers or ability to cross the cell membrane is more with brimonidine than apraclonidine. That's why we always say that brimonidine tend to be a more effective agent in treatment for glaucoma than with apraclonidine. But it also has certain pitfalls which we will be discussing up in few minutes. Please remember that alpha 2 agonist, especially brimonidine, can be used for prophylaxis of intraocular tension spikes post laser or post surgery. Immediately after that, to prevent the spikes of intraocular pressure, we also use especially brimonidine as a prophylactic therapy also. And the next drug, we have carbonic anhydrase inhibitors, which we have already explained, guys. We have 2 major types of carbonic anhydrase inhibitors, drugs which can be given via the systemic route and the drugs which is given via topical route. We have systemic or per oral or intravenous route and topical route. Per oral or intravenous drugs, a famous one, everyone knows it, astazolamide. Astazolamide, one of the, I hope you remember that, no? We have read it in diuretics, exactly. We have read it in diuretics. We have topical carbonic anhydrase inhibitors, which includes dorzolamide and brinzolamide. Dorzolamide and brinzolamide, easier to find it out, right? The drug name is going to be ending up with zolamide, astazolamide, dorzolamide and brinzolamide. What's the mechanism of action? Carbonic anhydrase type 2 is getting inhibited, thereby decreased aqueous synthesis. I hope you remember that. Shall we have a small recap of what we have seen again? Yeah, first drug was prostaglandin, F2 alpha analogues, increases drainage. The next one was beta blockers, decreases secretion. Carbonic anhydrase inhibitors, decreases secretion. Alpha 2 agonistic agent both decreases secretion and increases outflow. Both these mechanisms will be there for alpha 2 agonistic agents. Moving on to the next and the recent drug, and that is netarsudil, which is given as 0.02%. It's actually a Rho kinase inhibitor. What is Rho kinase, guys? Rho kinase is nothing but it's an effector organ for a G protein coupled receptor. Like how we have adenylyl cyclase, we have phospholipase C, we also have Rho kinase. Apart from netarsudil, we also have one more drug called as fasudil. Fasudil. Fasudil is being utilized in treatment for congestive cardiac failure and angina. For congestive cardiac failure and angina, fasudil is getting is been there, and it's also a Rho kinase inhibitor. We have netarsudil. What's the mechanism? It's going to be increasing trabecular outflow. Now we have the third drug on my left hand, and that is increased outflow via trabecular meshwork route. It is used for treatment for open angle or ocular hypertension. Most important adverse effect is patients might be developing whorl-like corneal microdeposits. We have whorl-like corneal microdeposits. Corneal microdeposits can be seen with many different drugs, guys. The most common cause is going to be amidor. I'm talking about corneal microdeposits. Corneal microdeposits can be seen with amiodarone. It can be seen with ciprofloxacin eye drops. It can be seen with ciprofloxacin eye drops, also with netarsudil. But here, the kind of deposits is not like a normal one. It's like a whorl pattern. It follows a pattern, and that is whorl pattern, also called as corneal verticillata. Whorl-like pattern of cream-colored lines can be seen with the netarsudil. As I've told already, netarsudil is not the most common cause. Amiodarone is going to be the common cause of corneal microdeposits, but whorl-like patterns can be seen classically with netarsudil. Simply put, I am going to be classifying the drugs into two major classes. Drugs which is going to be decreasing aqueous formation and increasing aqueous outflow. The first one we have, beta blockers, betaxolol, cartiolol, levobunolol, metoprolol, timolol. All these drugs, when given via topical route, is associated with ocular irritation. Patients might develop dry eyes, and as I've told, whenever it's administered as a topical route, the drug might enter via the conjunctival veins, or it might be drained back via the nasolacrimal duct, and the drugs is getting absorbed again into the systemic circulation. Patients might land up in bradycardia or heart block or heart failure, or in your respiratory system, patients might be landing up in bronchial asthma and COPD. The second drug is alpha agonistic agents. We can simply put it as alpha 2 agonistic agents, right? Why? Because it has got both the mechanisms. Apraclonidin, brimonidin. Again, it tend to produce red eye. Most and very important sentences are the next two sentences, guys. Ocular irritation, mydriasis and eyelid retraction are classically seen with apraclonidin, whereas sedation and respiratory arrest in children are classically seen with brimonidin. Why? I hope you remember that, no? We have explained something called as lipophilicity. Which is having more lipophilicity? Brimonidin carries more lipophilicity. When given in children, brimonidin, when given in case of children, because of its high lipophilicity, it tends to cross not only the cellular membranes, it also crosses blood-brain barrier, causing sedation, and there might be CNS adverse drug reactions, further producing respiratory arrest in terms of children. That's the reason why brimonidin is contraindicated in children who are less than 2 years of age. Children who are less than 2 years of age, brimonidin is contraindicated because it tends to cross the blood-brain barrier, producing CNS adverse drug reactions, which is least seen with apraclonidin, but it carries its own set of adverse drug reactions, which includes eyelid retraction. Again, cerebral insufficiency and in Raynaud phenomena, postural hypotension, hepatic renal impairment, we have to be constantly monitoring the drug dose which has been administered. Carbonic anhydrase inhibitor, again topically we have dorzolamide, brinzolamide. Systemic we have astazolamide and one newer drug which is methazolamide. These drugs, when given via systemic, especially astazolamide, when given via those route, it tend to be associated with transient myopia. Patients might carry nausea, diarrhea, loss of appetite, lassitude, and renal stones. Of course, an important adverse effect of renal stones, astazolamide is going to be renal stones. Topical route, it is associated with lesser ones, irritation and redness, but it is currently not being preferred. Why? Because of systemic adverse drug reactions, which might be possible, especially with those drugs. So which is currently preferred, guys? Drugs which is increasing aqueous outflow, especially prostaglandin F2 alpha analog agents. F2 alpha analogues like bimatoprost, latanoprost, as I've told, tafluprost, travaprost, and uniprost. Out of all this, uh, uh, these drugs tend to produce brown discoloration of iris. Not only that brown discoloration of iris, it also produces periocular pigmentation. So whenever you use latanoprost as an eye drops towards a single eye, and there might be iris pigmentation and periocular pigmentation, which appears like to say whenever someone has punched over his face. To prevent that, usually it is been administered on both the eyes. Especially not only brown discoloration of the irises, even the ocular irritation and redness, all these three are not especially because of that drug, it's because of the additive which is there along with latanoprost, benzalkonium. Tafluprost which is given here usually is devoid, tafluprost which is given here usually is devoid of that additive which is benzalkonium chloride. So we can't see ocular irritation or redness with tafluprost. Apart from all this, it might also produce lengthening of eyelashes, which we used to call them. Not only lengthening, additional row of eyelashes also can be seen, which we used to call it as hypertrichosis. That's why even bimatoprost has been tried for the treatment of patients who has less development of eyelashes. Patients might land up in macular edema. Increasing outflow, again we have alpha 2 agonistic agents, and what are those? Apraclonidin and brimonidin. As I've told previously, it carries both alpha 2, always 2. Cholinergic agonistic agents. Why cholinergic agonistic agents is going to be useful in this condition, guys? See, here is where the lens is, and here is where the iris is. If you give a constrictor agent, that is pupillary constrictor agent, and that is what your pilocarpine is, because these drugs are associated with the development of meiosis, not mydriasis, right? Because it's producing meiosis, we can expect the iridocorneal angle to open. Because of that opening, there might be more drainage of these drugs. Also, due to vasoconstriction, there might be decreased synthesis of aqueous humor also. These drugs are associated with ciliary spasm, which might be producing headache. There might be myopia, dim vision, cataract, and iris and lens adhesion also can be expected with pilocarpine. Moving on to the last important drug, and that is Rho kinase inhibitors, netarsudil. As we have seen already, it is associated with red eye, ocular irritation, and bowl-like deposits, corneal verticillata. If you are seeing it currently, please go back and take a screenshot of these two different tabular columns, guys. Very important for your pharmacological exams, be it your university or be it your NB exams, is going to be very much important, guys. What are the combinations which are available in the market? We have many Humpty number of combinations, because currently, as I have told, PGF2 alpha analogues are the drug of choice. If a patient is not responding properly, we can opt for a beta blocker. So we have lots of combinations which has been available along with beta blockers. That is, we have latanoprost, latanoprost and timolol. This is the combination between prostaglandin F2 alpha analog and a beta blocker. Travaprost, F2 alpha analog and a beta blocker. Dorzolamide and a timolol, carbonic anhydrase inhibitor and a beta blocker. Brimonidin and a timolol, alpha 2 agonistic agent and a beta blocker. Brinzolamide and timolol, again a carbonic anhydrase inhibitor and a non-selective beta blocker. Brinzolamide and brimonidin, carbonic anhydrase inhibitor and an alpha 2 agonistic agent. Netarsudil and latanoprost, Rho kinase inhibitor and a prostaglandin F2 alpha analogues. But majority of them are not available in the market, but usually it's not been advised to start the therapy especially or immediately with the combination therapy. It's we used to call them as an irrational therapy. Usually it is advisable to start with the prostaglandin F2 alpha analog, and if the patient is not responding properly, we can go for a beta blocker. Even if the patient is not responding for beta blocker, we can go for combinations. That's the next step of management according to our current medical diagnosis and treatment. What are the other treatments? These are pharmacological therapies. What are the other treatments which we have? We have two major ones. One is called as trabeculoplasty, which can be classified into argon laser trabeculoplasty and selective trabeculoplasty. Usually selective trabeculoplasty is currently being preferred. Also we have one more thing called as trabeculotomy, but it is usually not preferred because except in terms of emergencies, because there is more chances of scarring to be formed during the surgeries. In those conditions, what we do is we just make an artificial hole in the iris because the pressure is getting developed, right? There is no proper drainage from the posterior chamber towards the anterior chamber. So what will happen here, we have we just put a hole on the iris and we put up a small like a drain over there, which tends to drain up, which tend to producing the response, which tend to be helping the drainage of all the aqueous from one area to one another area. Usually it's not been preferred. Usually majority of the patients are currently being best treated with pharmacological therapies. I am talking regarding open angle glaucoma or chronic simple glaucoma. I am not talking regarding acute or acute congestive or angle closure glaucoma. Let's talk regarding the drugs which can be used for acute congestive glaucoma or angle closure glaucoma. This definitive therapy is going to be surgical or laser iridotomy. What are the drugs which we have? As per pharmacological treatment, we can opt for hypertonic mannitol because we need to immediately decrease the intraocular pressure. We opt for hypertonic mannitol. Acetazolamide, the carbonic anhydrase inhibitor. Miotics, not administered as immediate therapy because as I've told, pilocarpine, even though it has been applied as a treatment process, is not used as an immediate therapy because you have to keep this concept in mind because that's what the case scenario was. We'll go back to that again. Beta blockers can be administered, aprachloride or latanoprost also can be administered. Now comes the query. Use of pilocarpine in this patient. Can we use it or not? What is the use of pilocarpine, especially in terms of glaucoma? Pilocarpine, as I've told, car means or simply is going to be like carbachol. Car is going to be carbachol. It's a cholinergic agonistic agent. It's a cholinergic agonistic agent or muscarinic agonistic agent. It tends to constrict the pupil. Because of it, there is going to be the corner area, the angle pressure is going to get relieved out. Usually it's not recommended because it's going to be extremely short acting in nature and cholinergic adverse drug reactions are very much common with pilocarpine. Because of these reasons, usually pilocarpine is not recommended for treatment for glaucoma. What about this patient? As I've told in this case scenario, a 61-year-old man who presented with complaints of tubular vision or tunnel vision, loss of peripheral vision, optic nerve damage, cupping in the disc, and intraocular pressure was raised more than 40 millimeter or more than 30. If it is more than 40, we have to opt for surgery. If it is more than 25 or 26, and the patient has been diagnosed with open angle glaucoma and the patient was treated with pilocarpine. What about the rationale of usage of pilocarpine as an appropriate first line therapy in treatment for primary angle glaucoma? No, we don't use it. What's the drug of choice, buddies? Exactly. Prostaglandin analogues are going to be the drug of choice in those conditions. Try to answer these questions, guys. With this, we are going to be finishing off this case based learning, especially we are targeting the glaucoma related ones. Comprehension questions. The first question, pilocarpine causes constriction of pupils via which receptors agonism? Again, I am not going to be giving up the answers for you. This question is for analyzing your own knowledge based on the sessions which we have for the past half an hour. Pilocarpine causes constriction of pupils via which receptors agonism? If patient is not responding to PGF2 alpha analogues, what might be the next step in management? All this has been already been taught in this first half an hour, buddies. What are the common methods of evaluation of intraocular pressure? What's the most common mechanism of drainage of aqueous humor? With this, we finish off today's case-based learning. Thank you for joining back for this Clinical Thursday. We'll meet up with one more important and interesting case in the next week or in the following weeks in one another subject, one another expert faculty who is going to be teaching a particular case scenario. Thank you so much for this.